All right, ready to jump into another deep dive. Today, we'll be tackling urologic surgery essentials. We're going to break down some pretty dense surgical text, the stuff you provided, and pull out the need-to-know info. And keep in mind, we're going for that detailed, thorough understanding. No need to dumb anything down because, well, you're already a surgeon.
Exactly. Think of it like a super focused review, hitting those high yield concepts, those surgical nuances that really matter when you're in the OR.
Love it. So let's start at the very beginning, right? Urinary system anatomy, the foundation. The text really hammers home those tricky anatomical spots, the spots that can really make or break a surgery. What are some of those key anatomical things we got to keep in mind?
Well, you got to start with the kidneys, right? Tucked away up there in the retroperitoneum. Offers some protection, sure, but also leaves them vulnerable to blunt trauma. But here's the thing. Here's what's interesting. Their blood supply. It's unique. Really extensive collateral circulation, multiple vessels coming off the aorta along the whole length of the ureters. That means, we can move them around a lot during surgery without messing up the blood flow.
That's a really good point, especially when you think about those more complex procedures where
Yeah.
you really need to manipulate the kidneys.
Yeah.
All right, let's follow that urine flow down to the ureters. What about those anatomical danger zones there?
The ureters, like delicate little pipelines. And there are three main constriction points you got to be super careful with. First, you've got the ureteropelvic junction, right where it hooks up with the kidney. Then there's the spot where it crosses those iliac vessels. And of course, the ureterovesical junction, right as it goes into the bladder. These are the prime spots for stones to get stuck, which, can be a real pain, surgically speaking. But it's more than just knowing where these points are. It's understanding their blood supply. It's segmental, sourced from all these vessels along the way. That means if we're not careful during dissection, we could really cause some ischemia.
Absolutely.
Hey,
Damage to even a tiny segment can really have a huge impact downstream.
speaking of downstream, what about the bladder? This is a pretty, a dynamic organ. It changes position depending on how full it is. It's got different relationships to everything else depending on whether you're talking about a male or a female patient. Oh, the bladder's definitely a mover and shaker. Always got to consider that during surgery. Easy to injure during abdominal entry, especially if it's distended. You really have to know its anatomy inside and out, and that includes how prior surgeries might have changed things. Avoid those accidental injuries.
And speaking of anatomy, the bladder's structure itself is pretty wild too. That specialized lining, that urothelium, it acts as a barrier. And then you've got the detrusor muscle for pushing out urine. It's like, I don't know, some high security vault with a built-in ejection system.
Yeah, that's one way to put it. And just like those ureters, the bladder's got a great collateral blood supply, so there's some wiggle room there. But don't get too comfortable. Got to know your anatomy.
For sure. All right, let's shift gears a bit. Let's talk about how we as urologists have basically harnessed technology, right, to
Mhm.
see and treat these structures. I'm talking about endoscopic surgery.
Hmm.
The text points out that urologists were really pioneers in endoscopy, like early adopters, really shaping its development.
Oh, absolutely. We were right there at the forefront, some of the first to really see the potential of minimally invasive techniques. And it all started with cystoscopy, our window into the lower urinary tract.
Cystoscopy, it's like the cornerstone of urology, right? The
Yeah.
text goes through a whole bunch of uses for it. What are some of the main ones, the highlights?
Oh, think of it this way. It's our go-to for basically anything in the lower urinary tract, blood in the urine, problems peeing, infections, blockages, the whole nine yards. We use it to keep an eye on things after cancer treatment, to fish out foreign objects, even to assess trauma. We can even get a peek at the upper tract, by using ureteral catheters with contrast.
Super versatile tool.
Yeah.
Okay, now, when it comes to cystoscopy, there's the choice between rigid and flexible scopes. What are the things you consider when you're choosing between the two?
Well, the rigid ones, those are your workhorses. Great optics, big working channel, which means you can irrigate better and get your instruments in there. Plus, they're pretty easy to use, but they can be less comfortable for the patient, especially if they're awake. The flexible scopes, on the other hand, they're smaller, easier to maneuver, and patients tend to tolerate them better in the office. You get a more complete view of the bladder, but you have to deal with a smaller working channel.
Right, right. And of course, the text reminds us that we use the French system for sizing, which, for anyone who needs a refresher, it refers to the outer circumference in millimeters. So a 20 French cystoscope, that would have a 20 millimeter circumference.
Exactly. Gotta know your sizing helps you pick the right tool for the job, and for the patient, of course. Okay, now, beyond cystoscopy, you've got your upper tract endoscopy, ureteroscopy and nephroscopy.
Yeah, those are the tools for reaching further up the urinary tract, taking care of problems up there. What are the main differences between those two?
So ureteroscopy, that's mostly used for stones, in the ureter and the kidney. But it's also really helpful for visualizing, inspecting, and even treating other stuff up there. We've got both semi-rigid and flexible ureteroscopes. Semi-rigid, they're good for reaching the lower and middle ureter. But if you got to navigate that twisty-turny anatomy of the upper ureter and the renal pelvis, got to go flexible.
Gotcha. And nephroscopy. That sounds like we're going straight to the source.
You got it. Nephroscopy, that's when we access the kidney directly, percutaneously. Usually we reserve that for those bigger, more complicated renal stones or upper tract tumors. We use rigid and flexible nephroscopes, but rigid ones are more common, especially if you need to do something like fragment a stone.
Yeah.
Oh, and you're probably noticing more mini perc techniques these days, smaller instruments, less invasive.
It's amazing how those techniques have evolved.
Yeah, boss.
Doing so much now with minimal invasion. Now, the text talks about some key instruments, those essential tools for endoscopic surgery. Guide wires, ureteral catheters, stents, baskets, that kind of thing.
Ah, yeah. Those are like extensions of our hands, help
Yeah.
us navigate, manipulate, do all that fancy stuff inside the urinary tract. Guide wires, they're like your roadmap. They guide your catheters and other instruments into place. Ureteral catheters, those are for draining and doing contrast studies. Stents, absolutely essential for keeping things open if there's a blockage, from a stone or a tumor or inflammation. And then you've got your baskets or little retrieval tools, help us pull out stones, tumor bits, even grab biopsies.
Delicate work, for sure. Working within those tiny structures.
Mm-hmm.
All right, let's shift gears again. Time to talk about something that can really throw us for a loop. Urologic infections. And I'm not talking about your everyday UTI, but those complicated cases, the ones that really need a surgeon's expertise.
Oh, yeah. Complicated UTIs, they're a whole different ballgame compared to the uncomplicated ones. You really got to be on your toes with these because all sorts of patient factors, underlying conditions, anatomical quirks, they can really increase the risk of things going south.
The text mentions a few groups that are more likely to get these tricky UTIs. Men, people with diabetes, those with compromised immune systems, upper tract infections, resistant organisms, folks with anatomical issues. So what's the game plan? What are the key things to keep in mind when you're dealing with these patients?
Well, first things first, you can't just rely on what the patient tells you, their symptoms. Unlike uncomplicated UTIs, which often respond great to just starting them on some antibiotics, these complicated ones need a much closer look. We need those urine cultures, got to ID the exact bug, and figure out what antibiotics will actually kill it. Imaging is key too. You usually start with a KUB and a renal ultrasound, but if those show something fishy, like a stone or a blockage, you might be looking at a CT scan.
Gotcha. So it's a lot more nuanced, much more tailored to the individual patient. Now, the text digs into some specific genitourinary infections that surgeons need to know, and there's a lot there. Let's start with pyelonephritis. Sounds like it can be pretty straightforward outpatient stuff, or it can be a full-blown urologic emergency.
Yeah, pyelonephritis, basically an infection of the kidney, can definitely run the gamut. Sometimes it clears up with some oral antibiotics, no problem. Other times you're talking hospitalization, IV antibiotics, even emergency surgery.
Now, there are two types of pyelonephritis the text mentions that sound pretty interesting. Emphysematous and xanthogranulomatous.
Oh, yeah, those are the wild cards. Emphysematous pyelonephritis, that's a rare one, but serious. It's when you get gas-forming bacteria, usually E. coli, inside the kidney, often needs emergency drainage or even taking out the whole kidney. Xanthogranulomatous pyelonephritis, that one's a chronic thing, usually tied to blockages, infections, and stones. What's crazy is it's characterized by all these foamy macrophages infiltrating the kidney. Tough to treat, often needs surgery.
Sounds like those cases can really put a surgeon's skills to the test. Now, the text shifts to infections of the male genitals, starting with prostatitis. Sounds like we have to be super careful with that digital rectal exam, huh?
Absolutely. Doing a DRE on a guy with prostatitis, you run the risk of spreading the infection. It's a crucial part of the exam, but you got to be aware of that risk. And if it progresses to a prostatic abscess, you're usually looking at transurethral drainage to fix it.
Okay, now let's talk about epididymitis orchitis, where the infection basically crawls up from the urethra to the epididymis and the testicle. The text points out that the cause can actually differ depending on the guy's age. Important to remember when you're figuring out what's going on.
Oh, absolutely. Younger guys, you're thinking STIs. Older guys, more likely it's E. coli from a UTI. Scrotal ultrasound's your friend here. Helps confirm the diagnosis, rule out other stuff like torsion or an abscess, usually treat it with antibiotics, rest, elevate the scrotum. But sometimes you got to drain it surgically or even, in really bad cases, take out the testicle.
This next part really struck me. The text says that sometimes when epididymitis or orchitis is really advanced, it can be tough to tell it apart from other things like testicular torsion or hernia, even a tumor. Talk about a tough call.
Yeah, that's why you got to be thorough history, physical exam, the right imaging, scrotal pain, swelling. You can't jump to conclusions.
We talked about Fournier gangrene earlier, so
Mm.
let's skip ahead to a couple less common infections, but still important. TB and those parasitic infections. It's kind of wild that the genitourinary tract is the third most common spot for TB to show up outside the lungs.
It's a good reminder that TB can go anywhere, really. Got to keep it in mind, especially with patients who have risk factors. Treat it with anti-TB meds, long course. Sometimes you need surgery for complications like strictures or fistulas.
Parasitic infections, those used to be pretty rare, but with more people traveling all over the place, they're becoming more relevant for surgeons.
Definitely. You got to ask about travel history, especially if they have urologic symptoms. Cystisomiasis, echinococcal infection, filariasis. They're all in the text, and they each have their own weird life cycle and treatment challenges.
It's incredible what those parasites can do. One thing that really stood out to me, untreated schistosomiasis can lead to bladder cancer. That's a long-term consequence we want to avoid.
Yeah, that's why we got to be aware of global health issues. Take the right precautions when we travel.
Yeah.
Catching and treating these parasitic infections early is key to preventing those long-term problems.
All right, we've covered a lot of ground with infections. Let's move on to a topic that's super common but often misunderstood, voiding dysfunction and all of the stuff that goes with it. It's pretty amazing how the brain and the bladder work together to control something that seems so simple.
It's this intricate dance, nerves, muscles, signals going back and forth. When something gets out of whack, it can cause a ton of problems, from trouble holding your pee to trouble letting it go.
Let's start with neurogenic bladder. The text says it can present in all sorts of ways, depending on where the neurological problem is.
Yeah, that's the thing with neurogenic bladder, so many different faces. But if you recognize the specific symptoms, it can help you zero in on the underlying neurological issue, like a spinal cord injury. That's going to give you different bladder symptoms compared to damage to the nerves down in the pelvis.
The text goes into detail about specific parts of the brain involved in bladder control, like the pontine maturation center and the periaqueductal gray. Pretty complicated stuff.
Yeah, no kidding. But here's the cool part. When you understand how those brain regions talk to the bladder, you can actually start to predict and interpret the symptoms a patient might have, and that helps you target your treatment.
So cool how it all comes together.
Right.
Okay, let's talk about storage problems. Overactive bladder, OAB, the text says it's really common, especially in women.
Oh, OAB, that's a frequent flyer in our clinics. And for good reason. The urgency, going all the time, getting up at night, even leaking urine, it can really mess with your quality of life.
So for a surgeon, what's the first step in managing OAB? Do you go straight to surgery?
Nah, not right away. You always start with the less invasive stuff, behavior modification, bladder training, looking at their diet. Those simple things can be surprisingly effective for a lot of folks.
Urinary incontinence, that's another big one, especially for women, as the text points out. It breaks it down into stress, urge, and mixed incontinence.
Yeah.
How do we approach evaluating and managing incontinence from a surgical standpoint?
Got to do a thorough evaluation. No two ways about it. Figure out what kind of incontinence they have. Rule out any underlying medical conditions, anatomical issues, anything that could be contributing to the problem.
So we're looking for those red flags, something that says it might be more than just weak pelvic floor muscles.
Exactly. We look closely for any neurological symptoms, anatomical abnormalities, past surgeries, anything that could be playing a role. Not always a simple case.
The text really stresses those non-surgical treatments. Things like lifestyle changes, bladder training, pelvic floor muscle exercises, even losing weight. Like those are our first line of defense.
Absolutely. Those non-surgical approaches, they can be super effective, especially when you combine them. You can also try things like biofeedback that can help patients get better control of their pelvic floor muscles.
But what happens when those conservative things don't cut it? What about those patients who still can't get a handle on their incontinence? What are the surgical options?
For women, there are a few options. Bulking agents, which are injected to bulk up the urethra and help it close better. Midurethral slings, those provide support to the urethra. For men, it depends a lot on the cause. Could be prostate issues or maybe problems with the sphincter.
All right, let's move on to a condition that a lot of men deal with as they get older, benign prostatic hyperplasia, BPH.
Oh yeah, BPH, super common. Most men over 60 will have it to some degree. Basically, it's when little nodules grow in the prostate and eventually start squeezing the urethra, leading to those pesky urinary symptoms.
The text breaks down those symptoms into three categories: storage, voiding, and post-voiding. Can you give us some examples for each?
Sure. Storage symptoms, those are all about the bladder's ability to hold urine. Frequency, urgency, getting up to pee at night. Voiding symptoms, those describe problems with actually peeing. Hesitancy, weak stream, straining, stop and go flow. And then post-voiding symptoms, those are the sensations you get after you pee. Dribbling, feeling like you didn't empty all the way.
There's a point the text makes that's pretty interesting. The size of the prostate doesn't always match up with how bad the symptoms are.
Yeah, that's a good one. You can see guys with giant prostates who have barely any symptoms, and then others with small prostates who are totally miserable. It just goes to show everyone's different.
So how do we check a patient out if we think they might have BPH? What are the key things you're looking for?
You got to start with a thorough history and physical, including a DRE, to feel the prostate and see what it's like. Lab tests are important too, urinalysis to rule out infection, and a PSA test to check for prostate cancer.
The text also mentions measuring post-void residual volume and doing uroflowmetry.
Right. Post-void residual tells you how much urine is still hanging out in the bladder after they pee. Gives you an idea of how well they're emptying. Uroflowmetry measured how fast and how much they pee. Gives you a more objective measurement of bladder emptying.
Okay, let's talk about treatment. Seems like there are both medication and surgical options for BPH.
Yep, you got it. Mild cases, you can try meds like alpha blockers or 5-alpha reductase inhibitors. Those help relax the prostate and get things flowing better. But if the meds don't work or if there are complications, you might be looking at surgery.
The text calls TURP the gold standard for surgical treatment of BPH. Can you tell us a bit more about that procedure and all the different types?
TURP, transurethral resection of the prostate, it's all about using a special scope to take out the extra prostate tissue that's blocking the urethra. There are a few different types. Monopolar, that's the classic one, uses an electrical loop to cut tissue. Works well, but there's a higher risk of bleeding and electrolyte problems. Bipolar TURP, that uses a different kind of electrical current, so those risks are lower. Then there's laser TURP, where you use laser energy to vaporize or enucleate the tissue. That can be good for bleeding control and a faster recovery.
The text also talks about some less invasive treatments, things like microwave thermotherapy and radiofrequency ablation.
Yeah, those are usually done in the office, which is a plus for patients.
Yeah.
But they might not be as effective as TURP in the long run, and sometimes you have to repeat them.
And of course, there's still open prostatectomy. Seems like that's still a good option for really big prostates or complicated cases.
Oh, absolutely. Open prostatectomy, more invasive, sure, but sometimes it's the best choice.
Now, whenever you're doing surgery, you got to talk to the patient about the potential complications, right? The text mentions bleeding, infection, incontinence, stricture, that kind of thing, as possibilities with TURP.
Couldn't agree more. Informed consent is crucial. Got to make sure the patient knows the good and the bad before you go in there.
Now, let's move on to a topic that's becoming more and more important in urology: male reproductive medicine and sexual dysfunction.
It's a big part of men's health, for sure. As surgeons, we need to be comfortable talking about these sensitive issues. Got to be knowledgeable and compassionate. Male infertility and erectile dysfunction, those are the two big ones we see.
The text says male infertility affects a lot of couples, and there are tons of different causes, from anatomical problems to behavioral stuff, environmental factors, even things we do as doctors, iatrogenic factors.
Absolutely. It's multifactorial, that's for sure. You got to do a really good evaluation to get to the root of the problem.
This part really jumped out at me. The text specifically talks about infertility caused by us, by surgeons, things like damaging the vas deferens or the spermatic cord during groin or pelvic surgery.
Yeah, that's a harsh reminder, isn't it? Even surgeries that seem totally unrelated can impact a guy's ability to have kids. You really got to be careful. Meticulous technique, treat those structures with respect.
The text goes through the standard evaluation for male infertility. What are the key parts of that?
Always start with a good history, really detailed. Ask about their sexual history, any reproductive problems, exposures, infections, trauma, surgeries, family history. You got to cover it all. Then you got to do a really thorough physical exam, looking at the genitals carefully, looking for anything unusual, checking for varicocele.
And what about lab work? What tests do you order?
Semen analysis is a must-do. Look at things like volume, sperm count, how well they're moving, their shape, any signs of blood or bacteria. And we also check hormone levels, FSH, LH, testosterone, prolactin.
The text mentions that ultrasounds, both scrotal and transrectal, can give you a lot of information about the testes, prostate, and ejaculatory ducts.
Imaging is key. Helps you see what's going on anatomically, spot any structural problems.
Let's talk about treatment. Sounds like the options for male infertility really depend on what's causing it. Could be lifestyle changes, medication, even surgery.
Yep, that's the thing. Hormonal issue, maybe some medication to rebalance things. Blockage, might need surgery to open it up. Lifestyle factors. Work with the guy to make some healthy changes.
Okay, let's move on to erectile dysfunction, ED. The text talks about how common it is and that possible link to heart disease. We need to be on the lookout for that, right?
Absolutely. ED isn't always just about sex. It can be an early warning sign for heart problems, especially in younger guys.
So we're not just trying to help them get an erection, but maybe spotting a bigger health issue. What are the first steps you take when treating ED?
First things first, address those lifestyle issues. Smoking, being overweight, not exercising enough, all that stuff can contribute. Then you've got medications like those PDE5 inhibitors, Viagra, Cialis, those are popular.
What about testosterone replacement? When do you consider that?
We only use testosterone replacement if the guy actually has low testosterone, and it's been confirmed with testing. It can help, but you always got to weigh the benefits and risks.
The text also mentions those second-line treatments, injections, vacuum devices, penile implants. What can you tell us about those?
Injections, that's when you inject medicine directly into the penis to get an erection. Vacuum devices, they use suction to draw blood into the penis. Implants, that's when you surgically put a device inside the penis to help with erections.
I noticed the text reminds surgeons to be aware of those implants, especially during abdominal surgery. Don't want to accidentally damage them.
Good point. If you're operating in the pelvis, gotta keep those implants in mind. Take precautions.
Now, let's talk about testosterone deficiency, also called hypogonadism. Seems like that's another thing that gets more common as men get older.
It's true, testosterone naturally goes down with age. Not all men have problems, but some get hit hard fatigue, low sex drive, and, like we just talked about, erectile dysfunction.
How do you figure out if someone has testosterone deficiency, and how do you treat it?
Easy blood tests can check testosterone levels.
Yeah.
If they're consistently low, you might think about testosterone replacement. But like any treatment, you got to carefully weigh the pros and cons, individualize the approach.
Okay, we've covered a lot on male reproductive medicine and sexual dysfunction. Let's move on to something that's pretty common and can range from a minor annoyance to a serious problem. Kidney stones.
Oh yeah, kidney stones, urolithiasis. Affects millions of people every year, and it's on the rise, so we're seeing it more and more.
The text points out that kidney stones can be made of different things: calcium, uric acid, struvite, cysteine. Why is it so important to know what the stone is made of?
Because the makeup of the stone tells you how to treat it, and also what to do to prevent more stones from forming, like calcium stones, they're the most common, and changing your diet can make a big difference.
There's this really interesting detail about uric acid stones. They form when the urine is acidic, and things like eating a lot of protein or even tumor lysis syndrome can cause them. It's amazing how what you eat can directly affect whether you get kidney stones.
Right. It really shows you how everything in the body is connected. Diet plays a huge role in kidney stone formation. We work with patients all the time to make changes to their diet and prevent future episodes.
Let's talk about how kidney stones present, that acute presentation. You know, patients with renal colic can be pretty traumatic.
Oh, yeah. Renal colic, that pain you get when a stone is trying to pass through the ureter, it's some of the worst pain there is. People come into the ER in agony, just wanting relief.
The text says the classic symptoms are pain that comes and goes, usually in the abdomen, flank, or back. What are those red flags, the things that tell you it might be something more serious?
You got to be really watchful for signs of infection, like fever, chills, racing heart. And if the pain comes with nausea, vomiting, or they can't pee at all, that could mean there's a blockage that needs immediate attention.
The text really stresses that a CT scan, without contrast, is the best way to check for kidney stones. Why is that?
CT scans are great for spotting stones, and they're very accurate. Plus, you don't need contrast dye, which can be a problem for people with kidney issues.
All right, now let's talk about pain management.
Yeah.
These patients are hurting. What do you do to relieve that pain?
The main thing is to get the pain under control quickly. Usually we use IV NSAIDs or opioids. Once the pain's manageable, Then you can figure out the best treatment plan.
The text mentions something called medical expulsive therapy.
Oh yeah, that's when we use medications, usually alpha blockers like tamsulosin, to relax the ureter and help the stone pass. Works pretty well for smaller stones.
But what if the stone's too big to pass on its own, or there are complications? What are the surgical options?
We've got a few tools in our toolbox: ESWL, ureteroscopy, PCNL.
Let's break those down, starting with ESWL. How does that work?
ESWL, that's extracorporeal shockwave lithotripsy. You use shock waves, generated outside the body, to break the stone into smaller pieces that can pass more easily. Non-invasive, which is nice, but it doesn't work for every type or size of stone.
Ureteroscopy, we talked about that earlier with endoscopy.
Yep, you use a thin, flexible scope to get to the ureter, and then you can either pull out the stone or break it up. Often we use lasers to fragment it, and then little baskets or graspers to get the pieces out. Works really well for lots of stones.
And finally, there's percutaneous nephrolithotomy, PCNL. That sounds a bit more involved.
PCNL, that's usually reserved for the big boys, those larger or more complicated stones. You make a small cut in the back and stick a nephroscope, a special instrument, into the kidney to remove the stone. More invasive, for sure, but sometimes it's the only way to get those tough stones.
It's amazing how far we've come with technology. So many less invasive ways to treat kidney stones now. All right, let's shift gears to something that's, well, we hope we don't see it too often, but we got to be prepared for it. Urologic trauma.
Urologic trauma, it can range from minor bumps and bruises to really serious, life-threatening injuries. You need a systematic approach to make sure the patient gets the best possible outcome, and often, time is critical.
The text talks about those standardized management guidelines for urologic trauma, like the ones from the WHO, the AUA, and the European Association of Urology.
Those guidelines are super helpful. Give you a framework for evaluating and managing these injuries. Helps make sure everyone's on the same page, using best practices.
Let's talk about specific types of trauma, starting with kidney injuries. The text says most of these are from blunt trauma and are more common in men.
That's right. The kidneys are vulnerable to those blunt forces, like car accidents or falls. First thing we do, always, is focus on the ABCs: airway, breathing, circulation. Same as any trauma patient.
The text talks about the imaging criteria for blunt and penetrating trauma.
Imaging is super important to figure out what's going on with the kidneys. For blunt trauma, a CT scan with contrast is usually the best way to see the damage. Penetrating trauma, you might need other imaging too, depending on how it happened and how stable the patient is.
The text mentions something called a one-shot IVU. What is that?
A one-shot IVU, that's a quick way to check the kidneys in your ureters. You inject contrast dye and take one X-ray of the abdomen. Good for those emergency situations, especially if the patient's heading straight to the OR.
It seems like we're being more conservative these days when it comes to treating kidney injuries.
Yeah, we're definitely seeing a shift toward non-operative management, especially for lower-grade injuries and patients who are stable. Sometimes all they need is close monitoring, bed rest, and pain meds.
But when do you have to operate? What makes you decide to go in surgically?
We operate for the higher-grade injuries: persistent bleeding, those expanding hematomas, or any signs of damage to the blood vessels. The goal is to stop the bleeding, fix any tears, and save as much kidney function as possible.
The text talks about a damage control approach for really bad kidney injuries. What does that mean?
So if you've got a really badly injured patient who's unstable, you got to prioritize. Sometimes you have to put off fixing the kidney and just focus on saving their life. That might mean packing the area to stop the bleeding, then coming back later to do a more definitive repair.
Ureteral injuries, they're not as common as kidney injuries, but they can be really tricky to deal with.
Ureteral injuries, they're sneaky. Easy to miss, especially if it's from penetrating trauma.
Yeah.
Gotta have a high index of suspicion. Sometimes you need delayed imaging to see if there's contrast leaking or a blockage.
The text says surgery is usually the best way to fix ureteral injuries. Are there ever times when you wouldn't operate?
Generally, you want to do surgery to put the ureter back together, but there are exceptions. If it's an old injury that was missed, or if the patient's too high risk for a big surgery, you might try stents or percutaneous drainage.
Bladder injuries. Those are often linked to pelvic fractures, right? What are the important things to consider when you're checking out these patients?
Gotta know how the injury happened. A blow to the pelvis can rupture the bladder, either inside the peritoneum where urine leaks into the abdomen, or outside the peritoneum where it leaks into the tissues around the bladder. You need imaging, usually a retrograde cystogram or a CT cystogram to be sure. It shows you where the rupture is and how bad it is.
And how do you treat bladder injuries? Do they always need surgery?
Yeah, you're right. With bladder injuries, you don't always have to operate. It really
But
depends.
when'd you go in and fix it?
Well, those intraperitoneal ruptures, the ones where the urine leaks into the belly, those almost always need surgery. Got to close that hole, prevent ongoing leakage. But the extraperitoneal ones, where the urine leaks into the surrounding tissues, those can often be managed conservatively, catheter drainage, usually. But there are times you got to operate, like if there's bleeding that won't stop, or another organ is injured, or if there's something stuck in the bladder.
The text really emphasizes getting a watertight closure when you're fixing those bladder injuries. What are some of those, key surgical principles?
Two-layer closure, that's your standard approach. Absorbable sutures, of course. And sometimes you might need to throw in an omental flap to reinforce things, especially in those more complex cases.
Urethral injuries, kind of like those ureteral injuries, can be subtle, easy to miss. What are the things we should be watching out for?
Urethral injuries, you often see them with pelvic fractures or those straddle injuries. Gotta have a high index of suspicion. And we always do a retrograde urethrogram, where you inject contrast dye into the urethra. That'll show you any tears or disruptions.
And how do you treat those urethral injuries? Seems like the location and how bad it is play a big role.
You're right, location matters. Anterior injuries, those involving the penile urethra, sometimes you can just fix them directly or maybe just drain them with a catheter. Depends how bad it is. But the posterior injuries, those involving the prostatic and membranous urethra, those are more complex, often need a staged reconstruction.
The text mentions something called early catheter realignment for those posterior urethral injuries. It sounds a little, I don't know, controversial.
Yeah, it's a bit of a debate. The idea is to try to line up those torn ends of the urethra using a catheter. Less invasive than immediate surgery, sure, but it has its risks. And the long-term results, well, those are still up in the air. It's not something you try lightly. Needs an experienced urologist and the right patient.
Okay, last but not least, we've got those genital injuries. Can be anything from a simple bruise to a crazy laceration or avulsion.
With genital injuries, your approach really depends on how it happened and how bad it is. Little bruise, you just watch and wait. More complex stuff, you got to explore surgically and fix it up.
The text specifically mentions penile fracture. Rupture of the tunica albuginea.
Penile fracture,
Yeah.
yeah, usually happens from blunt force during sex. Classic presentation, that sudden, painful snapping feeling. Often needs surgery to prevent deformities or problems with erections down the road.
And of course, testicular rupture. That needs surgery right away to try and save the testicle.
Absolutely. Time is of the essence. Got to get in there and try to preserve testicular function, minimize those complications.
The text wraps up trauma with damage control techniques. Can you give us a quick rundown of what that means?
Okay, so let's say you've got a patient who's really unstable, life-threatening injuries. You got to prioritize, right? Sometimes you can't fix the urologic problem right away. You might have to pack the area to stop bleeding, put in temporary drains or stents, even take out a kidney if the bleeding's uncontrollable, stabilize the patient first, then deal with the urologic stuff once they're stable enough for surgery.
It's a good reminder that in trauma, sometimes you can't fix everything right away.
Yeah.
It's about buying time, giving the patient the best chance to survive.
Exactly. Trauma's all about priorities. Do what you got to do to keep them alive, then worry about the rest.
Okay, so let's move away from those external injuries, the trauma cases. Even without all that, we can still have some pretty intense urologic emergencies. The text highlights a few that need immediate attention. Gotta act fast.
Oh, yeah. Things like testicular torsion, priapism, those can go downhill in a hurry. Gotta recognize them quickly. Delaying treatment, well, that can have some really bad consequences.
Let's start with testicular torsion, which we touched on a little bit before.
Yeah.
The text really emphasizes the pain, how intense it is, and the urgency of the situation.
Testicular torsion, there's no messing around with that. It's a surgical emergency. The spermatic cord, the one that supplies blood to the testicle, it gets twisted, cutting off the blood flow. Classic presentation, sudden excruciating pain in the scrotum, often comes with nausea and vomiting.
And the text is clear, gotta operate right away to save the testicle. Every minute counts.
You got it. The longer that blood supply is cut off, the more damage there is, and the higher the risk of losing the testicle. No time to waste. Straight to the OR.
While we're talking about those urgent scrotal problems, the text mentions gross hematuria with clot retention as another potential emergency.
Yeah, that one. Big blood clots blocking the bladder outlet. That can lead to urinary retention, and man, it's painful. You see it sometimes in patients on blood thinners, but it can happen after surgery, radiation, trauma too.
The text says the first thing you do is try to flush out those clots with a catheter. But what if that doesn't work? What's the next step?
If irrigation doesn't do the trick, you might have to go in with a cystoscope. That way you can see the bladder directly and take out the clots manually.
Priapism, that's another non-traumatic urologic emergency. I don't imagine most surgeons see it all that often,
hmm
but the text really emphasizes the importance of recognizing it and knowing the difference between the two main types.
Priapism, it's not super common, but it's definitely an emergency. It's when you have an erection that won't go away, and it's not from being aroused. And here's the key. There's ischemic priapism and non-ischemic priapism. They need to be managed very differently.
The text makes it clear that ischemic priapism is the one to really worry about.
Ischemic priapism, that's also called low-flow priapism. It's when the blood flow to the penis is blocked. You get a painful, rigid erection, and if you don't treat it, it can cause permanent damage. It can happen in guys with sickle cell disease or from certain meds, leukemia, even trauma.
Non-ischemic priapism, it sounds like it's not as urgent.
Right. Non-ischemic or high-flow priapism, that usually happens when an artery in the penis gets injured, the blood flow gets all messed up. It's usually not as painful, and the damage isn't as likely to be permanent.
So how can you tell the difference? What are you looking for?
History and physical exam, those are essential. You also check the blood gas in the corpora cavernosa, the erectile tissue in the penis. Ischemic priapism, the blood is acidic, which means it's not getting enough oxygen. Non-ischemic priapism, the blood gas is usually normal.
Okay, so once you know what type of priapism it is, how do you treat it?
Ischemic priapism, you gotta act fast. You might start by aspirating, pulling out some blood from the corpora cavernosa, and then flushing it with saline. If that doesn't work, you can try injecting medicines like alpha agonists. They constrict the blood vessels. And if nothing else works, you might need to create a surgical shunt to bypass the blockage.
And what about non-ischemic priapism?
With non-ischemic priapism, you have a little more time. You might just watch and wait, see if it goes away on its own. Sometimes putting pressure on the area can help stop the bleeding. In some cases, you might consider angioembolization, which is when you inject a substance to block off the injured artery.
It's fascinating how two conditions that look so similar can need such different treatments. All right, let's switch gears again. Time to talk about a big one. Cancer, specifically urologic oncology.
Cancer, it's a scary word. And when it affects the genitourinary system, it can be really complex. As surgeons, we play a big role in diagnosing, treating, and managing these patients in the long run.
The text focuses on 4 of the most common urologic cancers: kidney, bladder, prostate, and testicular.
Yeah, those are the ones we see the most, so it's really important to know all the ins and outs of those cancers.
Let's start with kidney cancer. It's interesting that the text says most kidney cancers are now found accidentally, on imaging tests that were done for some other reason.
That's true. We're doing more imaging than ever before, which means we're catching a lot of cancers early, including kidney cancer. But it also means we're finding a lot of small tumors that grow slowly, tumors that might never have caused any symptoms. So now there's this debate about how to best manage them.
It's like we're catching them before they even have a chance to make themselves known. The text mentions the classic triad of symptoms for kidney cancer: flank pain, blood in the urine, a lump you can feel. But it seems like we don't see those so much anymore.
Right. Now you see a lot of patients who have no symptoms at all. Makes those regular checkups and those imaging tests even more important.
The text also lists a bunch of risk factors for kidney cancer: smoking, high blood pressure, obesity, being exposed to certain chemicals at work. It seems like it's a mix of lifestyle and environmental factors.
Absolutely. It's genes and environment all mixed up together. Those risk factors are important. We always consider them when we're evaluating patients and talking to them about prevention.
Now, the text goes into those different types of kidney cancer, the histology, clear cell, papillary, chromophobe. Why is it important to know which type it is?
Well, the type of kidney cancer can tell you a lot about the prognosis, how likely they are to do well. And it also guides treatment decisions. For example, clear cell renal cell carcinoma, that's the most common type, and it tends to be more aggressive than some of the others.
The text talks about that T&M staging system for figuring out how far the cancer has spread. Can you explain that to our listeners and why it's so important?
Sure. The T&M system, that stands for tumor node metastasis. It's a standardized way to classify cancers based on the size and location of the primary tumor, the T, whether it's spread to nearby lymph nodes, the N, and whether it's spread to distant organs, the M. It helps us make treatment decisions and figure out how likely someone is to do well.
So let's talk about treatment. What are the main ways to manage kidney cancer?
Well, it really depends on the stage and grade of the cancer, the patient's overall health, and what they want to do. For small, localized tumors, we might just do active surveillance. That means we watch it closely with imaging studies and only intervene if it starts growing or looking more aggressive.
And for bigger or more aggressive tumors, what are the surgical options?
If it's a larger or more aggressive tumor, surgery is usually the way to go. We have a few options: partial nephrectomy, where you take out just the part of the kidney with the tumor, and radical nephrectomy, where you take out the whole kidney.
The text talks about using minimally invasive techniques more and more for kidney cancer surgery, like laparoscopic and robotic surgery.
Those minimally invasive approaches are great. Smaller incisions, less pain, faster recovery, fewer complications.
And what about ablation? The text mentions that as an option for smaller tumors in patients who might not be able to have surgery.
Ablation, that's when you destroy the tumor with heat or cold. You can do it through the skin or during surgery. It's less invasive than surgery, but it doesn't work for every tumor.
What about those systemic treatments, like chemo or immunotherapy? When do those come into play for kidney cancer?
We often use those systemic therapies for advanced kidney cancer or if surgery isn't an option. Immunotherapy, that's where you use the body's own immune system to fight the cancer. It's shown really promising results lately. It's become a really important part of treating kidney cancer.
Okay, let's move on to bladder cancer. The text makes a big deal about the difference between non-muscle invasive bladder cancer and muscle invasive bladder cancer. Says it really affects the prognosis and the treatment.
You're right, that distinction is huge. Non-muscle invasive bladder cancer, or NIBC, that's when the cancer is just in the lining of the bladder. Prognosis is usually good. But muscle invasive bladder cancer, or MIBC, that's when the cancer has gone deeper into the muscle layer, much higher risk of spreading.
The text talks about how you evaluate bladder cancer cystoscopy, imaging studies, urine cytology. Can you break those down for us?
Cystoscopy, that lets you see the bladder lining directly. Take biopsies of anything that looks suspicious. Imaging, like CT or MRI, helps you see if the cancer's spread outside the bladder. And urine cytology, you look at the urine under a microscope, see if there are any cancer cells. Gives you more evidence.
So let's talk about treatment. How do you approach NMIBC?
The main treatment for NMIBC is TURBT, transurethral resection of bladder tumor. You use a special scope to take out the tumor from the bladder lining. We also sometimes use intravesical therapy, where you put chemo or immunotherapy drugs right into the bladder after the TURBT, kills any leftover cancer cells, reduces the risk of it coming back.
The text mentions BCG a lot as an intravesical immunotherapy drug. What's that all about?
BCG, that's Bacillus calmette-guerin. It's a weakened form of the bacteria that causes TB. When you put it in the bladder, it triggers an immune response that attacks the cancer cells. It's really effective at preventing recurrence for certain types of NMIBC.
Now, what about MIBC? The text makes it sound like the treatment's much more aggressive.
MIBC, that's a much more serious diagnosis, often needs a radical cystectomy. That means taking out the whole bladder, plus some of the surrounding tissues and lymph nodes. Sometimes we'll recommend neoadjuvant chemo, which is chemo you give before surgery, to try to shrink the tumor and make the surgery more successful.
Taking out the bladder, that's a big deal. What happens after? How do people pee?
Yeah, urinary diversion, that's a key part of bladder cancer treatment when you take out the bladder. There are a few different ways to do it, each with its pros and cons. One common way is to create a neobladder. That's a pouch made from a piece of intestine. It stores urine and lets people pee more naturally.
The text also mentions using an ileal conduit for urinary diversion.
Right, an ileal conduit, you use a piece of intestine to make a tube that connects the ureters to a stoma, an opening on the abdomen. Urine drains into a bag outside the body. It's not as, aesthetically pleasing as a neobladder, but it's reliable and it works.
Those are some complex procedures. It really shows you how bladder cancer can change someone's life.
No doubt about it. Bladder cancer can be life-altering. We have to approach these patients with compassion and expertise, give them the best care possible throughout their whole journey.
Let's move on to a cancer that affects a ton of men. Prostate cancer. It seems like how we manage prostate cancer has changed a lot over the years.
Oh yeah, prostate cancer, super common. And its management has definitely evolved. PSA screening, that's led to earlier detection, but it's also caused some controversy. Some people say it leads to overdiagnosis and overtreatment.
Yeah, the text mentions that debate about prostate cancer screening.
It's a tough one. There are good arguments on both sides. PSA screening has definitely saved lives. It's found cancers that would have been missed otherwise. But it also finds a lot of slow-growing tumors that might never have caused any problems, and that can lead to unnecessary anxiety in treatment, which can have its own side effects.
So what's the right approach? What do you tell your patients about PSA screening?
It's all about having an open and honest conversation. You got to lay out the potential benefits and harms of screening and then work with the patient to decide what's best for them. Consider their age, their health history, family history, what they want. It's not a one-size-fits-all kind of thing.
The text goes through how you evaluate a man if you think he might have prostate cancer.
Usually you start with a digital rectal exam, a DRE, and a PSA blood test. If those raise any red flags, you'd probably recommend a biopsy, a TRUS biopsy, where you use ultrasound to guide the needle and get those tissue samples to look at under the microscope.
The text talks about the Gleason grading system, says it's a big factor in figuring out how aggressive the cancer is. Can you explain that for our listeners?
The Gleason score, it goes from 2 to 10. It's based on how the cancer cells look under the microscope. The higher the score, the more aggressive the tumor is, the faster it's likely to grow and spread. It's really important for making treatment decisions.
All right, let's talk about those treatment options. What are the main ways to manage prostate cancer?
Well, like always, it depends on a bunch of factors. Stage and grade of the cancer, the guy's age and overall health, what they want to do. Low risk prostate cancer, you might just do active surveillance. Watch it closely with PSA tests, DREs, maybe repeat biopsies, and only treat it if it starts to get worse.
What about the more aggressive or advanced prostate cancers? What are the options then?
For more aggressive or advanced cancers, the main treatments are radical prostatectomy, where you surgically remove the whole prostate gland, and radiation therapy, which uses high-energy beams to kill the cancer cells. We might also recommend hormone therapy, which blocks the production of testosterone. Testosterone can make prostate cancer grow faster.
The text mentions different types of radiation therapy, like external beam and brachytherapy. What are the main differences between those?
External beam radiation, that's when the radiation comes from outside the body. Brachytherapy, you implant radioactive seeds right into the prostate gland. They both work well, but which one you choose depends on the specifics of the cancer and the patient's situation.
The text also talks about some newer treatments, like ablation and proton beam therapy.
Ablation, that's where you destroy the tumor with heat or cold, like using high-intensity focused ultrasound or cryotherapy. Proton beam therapy, that's a type of radiation therapy that's more targeted. You can deliver a higher dose of radiation to the tumor, but it doesn't affect the surrounding tissues as much. These newer approaches are showing promise, but we need more research to see how well they work in the long run.
What about focal therapy? The text mentions that as a new option that's gaining traction.
Focal therapy, that's the idea of targeting just the parts of the prostate that have cancer instead of treating the whole gland. It's less invasive, so fewer side effects, but it's still experimental. We need more research to see how effective it is over time.
Sounds like we're moving towards more targeted, less invasive treatments for prostate cancer.
That's the trend, definitely. Technology's getting better, we're learning more about prostate cancer, and we're always looking for ways to improve treatments and minimize those side effects.
Okay, let's wrap up with the last urologic cancer on our list, testicular cancer. The text emphasizes that early detection is super important and that it's very curable if you catch it early.
Testicular cancer, it's not common, but it's the most common cancer in young men, usually between 15 and 35. And you're right, it's highly curable, but you got to find it early and treat it.
So those self-exams and regular checkups, those are super important.
Absolutely. Every guy should be doing regular testicular self-exams. If you feel any lumps or swelling, go see your doctor right away.
The text says the usual presentation is a painless lump or swelling in the testicle.
That's the classic presentation, but some guys do have pain or discomfort.
What test do you use to check out a suspected testicular mass?
A scrotal ultrasound is the first thing we do. It's easy, no radiation, and really good for visualizing the testicle and seeing any abnormalities. We also do blood tests to check for tumor markers like alpha-fetoprotein, AFP, beta-human chorionic gonadotropin, beta-HCG, and lactate dehydrogenase, LDH. Those can be elevated in testicular cancer.
Okay, so you've got the diagnosis, testicular cancer. What happens next? How do you treat it?
Almost always, the first step is to take out the affected testicle, a radical orchiectomy.
And then what? The text mentions a bunch of options. Surveillance, radiation, chemo, RPLND.
Yeah, the treatment after orchiectomy depends on the stage and type of testicular cancer. Early stage seminoma, sometimes radiation to the nearby lymph nodes is all you need. More advanced cancers or non-seminoma cancers usually need combo chemo.
What about RPLND? When do you do that?
RPLND, that stands for retroperitoneal lymph node dissection. It's a surgery to remove the lymph nodes in the back of the abdomen where testicular cancer can spread. We often do it after chemo to get rid of any cancer cells hiding out in the lymph nodes. It's a tough surgery, can have complications, but it's an important tool for curing these guys.
It's pretty incredible. Testicular cancer used to be a death sentence, and now we've got these really effective treatments, really high cure rates.
It's amazing, isn't it? We've come a long way in understanding and treating cancer.
It's pretty amazing the progress we've made in urology. We've covered a ton of info in this deep dive. So let's try to distill it down a bit, to those most impactful points, the stuff a surgeon really needs to know.
Yeah, good idea. I think it's worth repeating. Got to know your anatomy.
Right.
Especially the urinary system, all those little variations, those potential traps, they can really make or break a surgery. We talked about the kidneys, how their blood supply is so unique, how you can move them around a lot without causing problems. And those ureters, so delicate, those 3 constriction points, always got to be thinking about those. And the bladder, always on the move, got to be aware of its relationship to everything else.
Yeah, if you're operating in the abdomen or pelvis, knowing the anatomy is absolutely essential. And we can't forget about those basic endoscopic procedures, the cystoscopy, ureteroscopy, nephroscopy. Those are our bread and butter, right? And
Yeah.
our eyes and hands in the urinary tract.
Exactly. And remember those specific genitourinary infections we talked about? Pyelonephritis, epididymitis, prostatitis. They can mimic other things, and if you miss the diagnosis, it can really cause problems for the patient. Got to be thorough with your evaluation.
It's all about connecting the dots, right?
Mm-hmm.
Putting together the patient's story, what you find on exam, the lab results. Then you can make the right diagnosis, give the right treatment.
Couldn't have said it better myself. And speaking of treatment, we talked about those non-traumatic urologic emergencies, testicular torsion, ischemic priapism. Those are the ones where you got to act fast. No time to waste.
Absolutely. Those are the cases where recognizing it quickly and doing something right away can make all the difference. You can literally save a patient's future health and well-being.
It's a big responsibility, no doubt, but it's also incredibly rewarding. And of course, we can't forget about cancer, renal cancer, bladder cancer, prostate cancer, testicular cancer. They each have their own unique challenges, and the treatments are always evolving.
It's so important to stay up to date on the latest research and guidelines, especially with cancer. Got to be able to offer our patients the best possible care. So before we wrap up, I'm curious, what's something really cutting edge in urologic surgery that we didn't talk about? Something our listeners should know about, something that's really pushing the boundaries.
Well, one thing that I think is super exciting is augmented reality in the OR. Imagine being able to see 3D holographic images of the patient's anatomy right there on their body in real time while you're operating.
Wow, that's amazing. Sounds like science fiction.
I know, right? But it's becoming a reality. Augmented reality could really change the game, More precision, fewer complications, better outcomes for patients.
It really is an amazing time to be a urologic surgeon. So much is happening. The field is constantly changing. We encourage all our listeners to stay curious, keep learning, and explore those areas that really fascinate you.
Well said. Keep diving deep into the world of urologic surgery. There's always something new to discover.